This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. This morning's speaker literally needs no introduction. All of you know Dr. Nanette Wenger, and she is known regionally, nationally, and internationally throughout the cardiovascular community. Nanette has been a faculty member at Emory for over 50 years and has made tremendous contributions to the cardiovascular community. Most notable, I guess, in the areas of cardiac rehabilitation, and then for the last several decades in the area of women's cardiovascular health. She's truly one of the iconic leaders of cardiology, and we're very, very honored to have Nanette here with us today to talk to us about a little bit more about women's health. Dr. Wenger.
Good morning. Thank you for the opportunity of presenting Cardiovascular Grand Rounds. And what I've chosen for our conversation this morning is the topic of transforming cardiovascular disease prevention for women. And I've subtitled it, Time for the Pygmalion Construct to End. These are my disclosures, and I'd like to start by reference to George Bernard Shaw. In 1912, in his play Pygmalion, that was subsequently adapted for the screen and the stage as My Fair Lady, we hear the protagonist saying again and again, "Why can't a woman be more like a man?" Well, I expect that what I'd like to do over the next hour is to explain that we do not want the woman to be more like a man in terms of cardiovascular prevention for three reasons. First, the traditional atherosclerotic cardiovascular disease risk factors impart a differential risk for women and for men. Secondly, there are a number of non-traditional atherosclerotic cardiovascular disease risk factors that are either unique to or predominant in women. And lastly, because gender-specific risk assessment and management have the potential to improve atherosclerotic cardiovascular disease outcomes for women. Now, this is a slide that I just have enjoyed showing over the past decade, because when I showed the slide up to the year 2000, what we tended to see was that whereas the decline in cardiovascular mortality in the United States was predominant in men, there really was no change for women. But since the year 2000, both for men and for women, there has been an abrupt decline in cardiovascular disease mortality. And as you can see, that decline has been even more abrupt for women. Now, about half of the mortality decrease is attributed to management of established cardiovascular disease, but the other half reflects preventive strategies, both primary and secondary prevention, so you can see why this is so important for women. As background, most of you are aware that cardiovascular disease is the leading cause of morbidity and mortality for women in this country, and that 1 of every 4 women ultimately will die of cardiovascular disease. Despite women's concern with cancer, their annual cardiovascular mortality is double that from all forms of cancer combined. And when we address the area of prevention, 2 of 3 women in this country have at least one major coronary risk factor, and as we all know, that percentage increases with older age. Now, I've shown you the global decrease in mortality, but what we've seen rather frighteningly is that for the younger women, here defined as age 35 to 54, their cardiovascular mortality is now increasing by about 1 percentage point annually, and that is reversing a trend of the past 4 decades. In the last 2 decades, we've seen among women that their Framingham risk scores, a poor predictor, but nonetheless there, are increasing. And probably the 2 major contributors are the obesity epidemic and the sedentary lifestyle. But all of this highlights the importance of providing preventive cardiovascular screenings for women. Now, women are not a homogeneous group, and we see major disparities. Let's address first the African American women. Almost half of the African American women have some form of cardiovascular disease. Hypertension, with a 44% prevalence, has an earlier onset in African American women. They are more likely to have metabolic syndrome. Their rates in mortality are greater than that for their Caucasian sisters. And when we look at risk factor burden at hospitalization for myocardial infarction, comparing white men, white women, black women, the largest risk factor burden is in the black women. And I will not have to cite many, many studies showing that the black women are less likely to receive evidence-based therapies. Very different story for the Hispanic women. Hispanic women have a doubled occurrence of diabetes as compared with non-Hispanic white women, and you see the numbers there. But there's an amazing health paradox that's not well understood, because the Hispanic women have a lower mortality and they have an increased life expectancy in comparison to their non-Hispanic white women. Now, several of these slides I'd like to show you, and these derive all from the American Heart Association's heart and stroke statistics. And here we compare in blue the white women and in red the black women. And you will see that they have more coronary heart disease, more stroke, slightly less lung cancer, and slightly more breast cancer. But the coronary disease and the stroke are really the prominent differences. And again, in terms of outcome, when we look both for age and for sex, heart failure, as you know, increases incrementally with increased age. But what we tend to see is that heart failure predominates in the older women, and very, very much so. What I'd like to do now is to look at the risk factors, the novel risk factors that are either unique to or that predominate in women. And the first that I'd like to address are complications of pregnancy, and to emphasize that a detailed pregnancy history is an integral component when we begin risk assessment for women, and that is women of any age. And those pregnancy complications that should be ascertained include preeclampsia, gestational diabetes, pregnancy-induced hypertension, and preterm delivery. All of these are early indicators of an excess of cardiovascular risk. Now, it's been said that pregnancy is the first stress test that a woman will undergo because there are cardiovascular and metabolic stresses. And they give us the potential to early predict future cardiovascular risk. Now, we're not certain whether these complications are the ones that impart the risk. I think rather it's the fact that there are shared risk factors among the women who develop cardiovascular complications and the women who develop preeclampsia. I think that it is not an A to B, but rather both of them have a commonality of underlying risk factors. And to give you some idea of magnitude, with preeclampsia and gestational hypertension in terms of cardiovascular risk, there's a 3 to 6-fold increase in the subsequent development of hypertension, a doubled increase of ischemic heart disease and stroke. And whereas preeclampsia, as well you know, subsides with delivery of the placenta, the residual endothelial dysfunction will persist for years. And in some studies, interestingly, I think some people haven't muted their mics. Will you do that, please? There is residual endothelial dysfunction, and in some settings that has been associated with an increase in coronary calcium on scanning. And not surprisingly, gestational diabetes will increase by 7-fold the subsequent development of type 2 diabetes. Now, what about oral contraceptive therapy? That does not increase cardiovascular risk in healthy women who have no risk factors, and that's the important modifier. But the smoking woman has a 7-fold increase in risk, and the woman who comes to oral contraceptive use with hypertension will have an increase in blood pressure. There is, however, a 1.5 to 2-fold increased risk in stroke, and that is more common with older age. Now, there's a difference with the data that we will look at with the different generations of oral contraceptives. The newest of the oral contraceptives actually lower blood pressure, but nonetheless, the risk for venous thromboembolism persists. The older ones that have been most prominently written about do increase risk for myocardial infarction. And therefore, the recommendation is that for the woman prescribed oral contraceptives, all of her healthcare providers pay attention to very precise cardiovascular risk factor control. Only recently addressed has been the issue of hormonal fertility therapy and the question as to how that relates to cardiovascular disease. And virtually the only good data that we have available are from a Canadian cohort from the 1990s until recent years. And interestingly, the women who had successful, and I've underlined that deliberately, successful fertility therapy had a lowered risk of all-cause mortality, non-fatal coronary ischemia, stroke, TIA, thromboembolism, and heart failure. But the question is, what was the issue with the women who did not have successful fertility therapy? That group has not been studied. That is the group that may have had repeated cycles of hormone. And this data, the Canadian data, was uniform across all age and income groups. But the important question that has been raised is, does this simply reflect the bias in selection of a healthy cohort? But again, very new information only because the question was asked. The one that we're all familiar with is menopausal hormone therapy. And in all of our academic lifetimes, these are the clinical data that have dramatically altered both clinical recommendations and clinical practice. And 2 years ago, the U.S. Preventive Services Task Force said that menopausal hormone therapy is not recommended for the primary prevention of any chronic condition. And based on data that a lot of us were involved in accumulating from Women's Health Initiative and FAHA's, menopausal hormone therapy not recommended for the primary or secondary prevention of any form of cardiovascular disease. Now let's change emphasis and go on to systemic autoimmune disorders that are highly prevalent and essentially selectively disadvantage women. And women who have systemic autoimmune collagen vascular disease are at increased risk of coronary disease and of cerebrovascular accident. In the woman with lupus, coronary disease is her leading cause of morbidity and mortality. In the woman with rheumatoid arthritis, there's a 2 to 3-fold increase in myocardial infarction and cardiovascular mortality. And the message is, again, screening for cardiovascular risk factors and intervention to control those risk factors. Now let's return to the standard coronary risk factors and look specifically at hypertension, examining the gender differences. Again, this American Heart Association formulation, the men in the blue, the women in the red. And prior to age 40 or 45, men are more likely to have hypertension. But with older age, hypertension increases dramatically among women, and the highest percentage in the older age group are the women who more typically have isolated systolic hypertension. Again, in terms of blood pressure treatment and control, when we look at the subsets by sex and by ethnicity, we're doing reasonably well with awareness and with treatment. But in terms of control, what we see is the lowest level of control is among Mexican-American males, but very prominently what we're seeing is not ideal levels of control in any subset of the population. But let's look specifically at hypertension in women. Actually, hypertension worldwide is the leading cause of cardiovascular disease. But in all of the studies, the population-adjusted cardiovascular mortality for women is almost double that for men. And as I've shown you, the women are much more likely to be hypertensive as they reach the Medicare population. But perhaps underappreciated is the impressive correlation of body mass index with systolic and hypertension in women. And what we see now as older patients increasingly are populating our wards and our clinics is that 80% of women in these United States older than age 75 have hypertension. And this seems to be unique essentially to the developed countries. because in the non-industrialized societies, you don't see this increase in hypertension with age. So there is certainly a major environmental component to this. And again, looking at these elderly women, 29% of elderly women have their blood pressure controlled, and almost double that number, it's present for men. When we look at the prevalence of smoking, I think that what we tend to see is that among the women, as you look at the different subpopulations, the white women, the black women, the Hispanic women, the Asian women, and the Native Americans, there's a wide disparity. But nonetheless, the point that I'd like to emphasize is that almost 17% of U.S. women currently smoke, and in the younger women, they are much more likely to initiate smoking behavior than are younger men. But what we've seen from these data that Huxley published just a few years ago is that your woman smoker is at 25% greater risk of a cardiovascular complication than the men who smoke. And as we look specifically at risk for myocardial infarction, smoking will triple the risk of myocardial infarction among women. Now, when we say cost-effective, smoking cessation by far is the most cost-effective risk modification in the U.S., and we all have to learn how to help our patients do this better. When we examine the prevalence of physician-diagnosed diabetes mellitus, what we tend to see, again, is the highest prevalence, again, among the black women, less so in white women, intermediate among Mexican American women, and this was the specific subpopulation of Hispanics that was studied. And when we look at the trend in the prevalence of diabetes, again, physician-diagnosed diabetes, looking from the 1980s to the present time, physicians are getting better with the diagnosis, but we still tend to see a substantial amount of undiagnosed diabetes, and it is often the undiagnosed diabetes that leads us to undertreat the cardiovascular risk. Now, diabetes preferentially disadvantages women because their cardiovascular risk, the diabetic woman compared with the diabetic man, is 19 as compared with 10%, almost double. Diabetic woman has a 40% increased risk of developing coronary disease, 25% increased risk in stroke. And when we see a patient in hospital with an initial myocardial infarction, about 25% of the women with that initial infarct are diabetic, as compared with 16% of the men. Now, the correlation of mortality in coronary disease is stronger for diabetic women than for diabetic men, and we're not sure what is the underlying pathophysiology. Does it relate to the adiposity, to the abdominal adiposity? Does it relate to insulin resistance? Because it's the diabetic description, but not the subsets. But no question that the diabetic woman has a more adverse coronary risk profile, and there tend to be clustering of the cardiovascular risk factors. When we look over time and examine the improvement in mortality among the diabetic and non-diabetic men and women going on from the 1970s, what we see is that there has been an improvement in mortality in men, both with and without diabetes, and in women without diabetes. The only subgroup with increased mortality are the diabetic women. And again, when we examine the cardiovascular risk factors, diabetic women have less adequate control of their traditional cardiovascular risk factors than do diabetic men. Now, cholesterol management has been on everyone's lips over the last years, and let's look at the way I think it will impact the care of women. Hypercholesterolemia has the highest population-adjusted cardiovascular risk for women, and that's about 47%. And there is no question that in every one of the studies, there has been similar statin benefit between women and men, and in the new cholesterol guidelines, there is no expression of gender differences. But what we've seen, of course, is that since November of last year, there's been a major change in the way we manage hypercholesterolemia. We're using the new pooled cohort risk equations, and those are gender and ethnicity specific. The lifestyle guidelines are similar, but we no longer treat to target LDL. We use fixed-dose statin therapy based on the risk categorization. And interestingly, though, only moderate dose statins are recommended for those older than 75 years, simply because there is lack of adequate data in an older population and lack of adequate data in both women and men at elderly age with high-dose statin. And as you know, the non-statin therapies are not recommended. And likely, if we will track the cholesterol control in women, I expect over the next couple of years what we will see will be an increase in statin use among women based on these guidelines and based on the new pooled cohort risk equations. We will likely see a decrease in the inappropriate use. We'll see a decrease in the use of non-statin therapies, and of course a decrease in laboratory testing because we are not using the treating to target. Now let's go on to obesity. And I don't have to tell you that the obesity epidemic in the United States continues to increase, both for women and for men, with 2 of every 3 women in this country being either obese or overweight. And what we see associated with that obesity is hypertension, dyslipidemia, physical inactivity, insulin resistance. And the obesity risk, as you can see by these numbers, is greater for women than it is for men. But again, as we look globally, in the low and middle income nations across the globe, obesity is double in women compared with men. But in the high income nations, obesity is equal in women and in men. So a severe problem with obesity in the low and middle income nations. What about physical activity? Certainly, it is not a surprise that women tend to be somewhat less physically active than men, but again, more prominent among the Black and Hispanic women is the prevalence of those meeting the old aerobic guidelines, those from 2008. Now, in the United States, about 1/3 of adults are physically inactive, somewhat more women than men. And looking globally, and I'm trying to address some global issues because we have been accused in the US of really centering only on our population and not considering global issues in terms of prevention risks. But in the Interheart study, the protective effects of exercise in all of the populations were greater for women than for men. Physical inactivity is indeed the most prevalent risk factor for women. 1/4 of US women report no regular physical activity, and for 3/4 of the women, they have less than the recommended physical activity levels. We do have research data. In the Nurses' Health Study, women who exercised regularly were less likely to develop diabetes, and even among the diabetic women in the Nurses' Health Study, physical activity decreased their risk of cardiovascular events. My conflict of interest is that I chair the Data Safety and Monitoring Board for that study. But secondary prevention, in every one of the cardiovascular guidelines, exercise-based rehabilitation is recommended as a Class 1A intervention, and women are 55% less likely to participate than men. Both the decrease in referral, the decrease in attendance, and the decrease in completion. I want to go on to psychosocial issues, and particularly to emphasize depression, because again, preferentially disadvantaging women. In the Interheart study, again globally, the psychosocial factors were much more important for women than for men by about 15%. And that included stress at home and at work, it included financial stress, it included major life events. And depression increases cardiovascular mortality independent of the severity of that depression. We're not certain what are the particular contributors. Some of it may relate to high-risk behaviors, some of it may relate to non-adherence to therapies, but there's no question that if we look at the young women, defined here as younger than age 65, with depression and established coronary heart disease, they have a higher mortality. And in a number of studies, we've seen depression as an adverse outcome risk factor in the setting of acute coronary syndrome. We are likely to see increased stress with the increase in global violence, with global financial instability. And very important, both in this country and elsewhere, is that there are major cultural taboos in access to care for emotional problems. I want to pick just one example of medication differences, and I could go through a list of them, but I will choose aspirin, because aspirin routinely recommended for primary prevention in middle-aged and older men, but not for women. The basis for this is the Women's Health Study, some 38,000 healthy, low-risk women above age 45. And what we saw is that below the Medicare age group, it prevented stroke, but not MI and not cardiovascular death, but a substantial potential for gastrointestinal bleeding. In the Medicare population of women, it prevented both stroke, MI, and cardiovascular death, but the risk for gastrointestinal bleeding was almost as large as the magnitude of the prevention, and the message is individualize. By contrast, in the Physicians' Health Study that involved only men, there was benefit for myocardial infarction, but not for stroke. And as well you know, in the secondary prevention setting, both women and men should be prescribed daily aspirin. Let me go on to address the issue of cardiovascular awareness in women, because if an individual is not aware of risk, preventive interventions don't ever appear on the landscape. And today, only 54% of women in this country recognize heart disease as their leading cause of death. It's hard to realize that the awareness campaigns, the NHLBI's Heart Truth campaign and the American Heart Association's Go Red for Women, are actually 15 years old. And in that period of time, the awareness increased from 30 to 56%. But recently, there's been a plateau with no increase in awareness among women that this is their major health risk factor. But importantly, the lack of awareness was greatest in the highest risk population, and those are the women of racial and ethnic minorities. But it is not only the women, but the healthcare providers, and lack of awareness among the healthcare providers translated into suboptimal application of preventive interventions, less appropriate diagnostic testing, and we within the last month have had new guidelines for diagnostic testing for women, less adherence to evidence-based guidelines, and not surprisingly, poorer outcomes. The message really is that the underrepresentation of women in the cardiovascular clinical trials and longitudinal studies, and even when they were included, the lack of gender-specific analysis, has limited the scientific database we have to make decisions for women. But the first step to personalized medicine is incorporating information about sex and gender differences when we treat our female patients. Now, what about adherence? What about adherence to recommendations? Actually, all of the studies have shown that it is comparable for women and for men. The characteristics that predict non-adherence, not surprisingly, lower socioeconomic status, educational levels, and depression. But in these studies, there were specific barriers identified for women, and those included family and caretaking responsibilities, fatigue, stress, and lack of personal time. I do want to spend the last few minutes addressing some of the global issues. And in September of 2011, there was a United Nations Summit on Non-Communicable Diseases. Actually, it was only the second time the United Nations had had a health summit. The previous one was some decades earlier on AIDS. And I've picked out from the inch-thick proceedings of that summit the specific issues that I found related to women. And what that summit identified was gender disparity in risk, in access to diagnosis, and in treatment. And that was linked with the empowerment of women and with the education of girls. In 2008, which were the data that were reported in that summit, there were about 9 million cardiovascular deaths in women across the globe, and that accounted for about a third of the cardiovascular deaths in women. And specifically listed in that summit was that the non-communicable diseases, most of which are cardiovascular, adversely impacts women's contribution to society, productive roles, reproductive roles, as consumers of healthcare, as providers of healthcare, but that women were identified as a vulnerable population because women constitute 60% of the world's poor and 2/3 of the illiterate adults, and therefore a major challenge to education and information. This comes from a paper that Divya Gupta and I did now 2 years ago, looking at the population-adjusted risk of cardiovascular disease by risk factors between men and women. And here the women are in the paler color, more hypertension, less smoking, about the same dyslipidemia, but diabetes, obesity, psychosocial factors, very, very important. Now, what are the challenges and what are the opportunities? Based on this UN summit and the follow-up for that gave challenges to countries, and with those challenges had risk reduction targets that now may help guide funding for some of those programs. 80% of the cardiovascular deaths were in low and middle income countries. And over this decade, it's expected that the global prevalence of cardiovascular disease will increase by 15 to 20%. And underlying this are unfavorable changes in cardiovascular lifestyle in the developing world. The urbanization, the Western diets, we have been exporting atherosclerosis, processed foods, and with that, obesity, hypertension, dyslipidemia, and diabetes. What is expected is that between 1990 and the end of this decade, there will be a 120% increase in cardiovascular mortality among women in developing countries, and that compares with less than 30% of women in the developed world. So the problem will be certainly here, but even more so overseas. But the emphasis is that in the InterHeart study, the modifiable risk factors accounted for 94% of the population-adjusted cardiovascular mortality for women. So these risk factors are modifiable. And what do I see finally as solutions? I think the key global issues that apply both here and what we do overseas is that we have to educate the population, and women in particular, about cardiovascular risk factors. The fact that many of them, most of them, are modifiable and many of them are behavioral. What we have to have women understand, both in our country and abroad, is that basic lifestyle modifications can lessen the occurrence and severity of hypertension, dyslipidemia, obesity, diabetes, and cardiovascular risk in women. Smoking cessation is at the top, again, the most cost-effective, but dietary intervention with decrease in sodium, saturated fat, increase in fruits and vegetables, and application of exercise. What we have to have are messages specifically targeted to women, and especially so because of the major potential increase in the low and middle income nations. We have to see that the organizations directed to women's heart health engage women on a community level, just as we here in Atlanta are trying within the Emory system to engage women on a community level. This is the way we can decrease the risk of cardiovascular disease, infarction, and sudden death. And what we need then is the development of programs, of policies, and national plans for cardiovascular prevention targeting women. I've said many times that women's health and women's cardiovascular health is not solely a medical issue. It relates to politics, it relates to economics, it relates to sociology, it relates to public policy. And this is where we have to go if we want to improve cardiovascular prevention for women. And I thank you for your attention. questions, comments, challenges?
All right, so first of all, just thank you for a fantastic talk, as always, Dr. Wenger. So people remotely, now you can turn on your microphones if you have questions and use your text box if you want, and we'll take some questions. I'll start with one. So at the beginning you talked about women and post-menopausal hormonal therapy, and so now we know that we shouldn't be using as primary prevention for osteoporosis or for cardiovascular disease. But the challenge we often run into is a woman who's on hormonal therapy, postmenopausal, women who's on hormonal therapy, has been on it for a long time for symptoms perhaps related to hot flashes, etc. And so now we're 10 years, 15 years later, what do we do? How do we work with those women, and what's the right strategy in that setting?
Well, again, I expect that this has also been a changing landscape because the information has extended to the women, and the use of menopausal hormone therapy, particularly the longer-term use, has dropped dramatically in the U.S. to where it is now about the same as it is worldwide. Previously, the U.S. essentially led the charge on menopausal hormone therapy. There's no question that that is the best therapy for the relief of menopausal symptoms, but using the FDA guidelines, it is the lowest possible dose for the shortest time, and this is what is recommended. I think it's important because we're now seeing a potential resurgence of something called bioidentical hormone therapies. For those of you who used to look years ago at Parade magazine, which tells you what the natural food stores will be pushing over the next several weeks or months, there were all of these bioidentical. The Food and Drug Administration has said that that term is illegal and may not be used in advertising because there is no evidence that it's bioidentical, and they have never been tested for efficacy or for safety. So I think that is really important. But again, the lowest dose of menopausal hormone therapy for the shortest period of time. Many women will say, I'm worried about cognition, about mood, about depression, about intellectual integrity. And again, in the Women's Health Initiative, the women on hormone therapy had actually a decline in cognitive function, statistically significantly greater than was present in the ones who were on placebo. So certainly no evidence of improved cognition and lessened dementia, and a potential increase in risk.
Thank you, Dr. Wenger. That was outstanding. My question is regarding the challenge of using a statin with the new guidelines for women. So we are no longer checking this level of lipids or LDL after we start these women on statin. That's challenging for me to continue to motivate women to do the diet and exercise modification. Secondly, it does not give any guidelines regarding should we try diet and exercise modification in these women who are overweight and totally not active, and try it for a few months and then consider statin. So it's kind of, I was at Washington, and Dr. Foodie was asked this question, and there were no real concrete guidelines. There was a lot of controversy and confusion. What is your take on this matter?
Remember that the guidelines don't say do not measure LDL. The guidelines simply say don't treat to target. And they do recommend measurement of LDL in terms of trying to ascertain adherence to medication. And the guidelines say that the high-intensity statins are anticipated to reduce LDL cholesterol by about 50%, the moderate intensity 30 to 49%. But again, if you read through the guidelines rather than just the items in bold, if these levels are not attained, there is the potential of adding other medications, etc. And then there are some other tests that are suggested that might help guide your decisions. It's simply that we're not repeatedly going to use targets, but rather use fixed dose high or moderate intensity statin. And measuring the LDL periodically for adherence. It's certainly adherence to statin therapy, but you may readily use it, as you've suggested, for adherence to the multiple other features that tend to be important. Oh,
From Sam
is
Sherman.
the aspirin dose perhaps, the bleeding perhaps dose-related? I think certainly it is. Remember that both in physicians and in women's, the dose of aspirin was 100 milligrams every other day, because at the time those studies were initiated, that was the way aspirin was dosed. Now our recommended dosing is 81 milligrams a day. So certainly the bleeding risk there was on the 100 milligrams every other day. I think it's reasonably applicable, and again, we have to be very careful that we're using the 81 milligrams, say for the patient who comes in and gets 325 milligrams of chewable aspirin with an acute coronary syndrome. Remember particularly that when we use the P2Y12 agent ticagrelor, that you must have the low-dose aspirin, lower than 100 milligrams, because the higher dose aspirins interfere with ticagrelor effect.
Thank you, Dr. Wenger. I wanted to know if any of the other autoimmune diseases have higher cardiovascular, the non-collagen vascular type, say multiple sclerosis.
The others have not as well been studied. The populations that have been studied best are the populations with lupus and with rheumatoid arthritis. And obviously there is a need for studying. This is one of the reasons why so many of us have requested that any of the studies that are done have gender-specific information and gender-specific reporting. I expect that the data are there. They've just not been disaggregated by gender, and that has to be done.
Well, thank you very much, Nanette, for a fantastic talk. We really appreciate it. Great talk. Thank you.
The preceding program is copyrighted by Emory University.